everyone, welcome back to my channel, and if you are new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, and give us a thumbs up. And please share with your friends and people you think you would also benefit from this content. Today we have a very special guest, and he's Colin Davies. He's a physical therapist and he graduated in 1971. He became a clinical associate of Robin McKenzie in 1974, and he is a member of the teaching faculty of the McKenzie Institute since 1984. And he's going to share with us his experience since the beginning of the method and how it changed and evolved over the years, so you can miss it. Hi, Colin. Welcome to PT Pro Talk. How are you today?
Well, very well. Thank you, Marianne. Very well. I've got a few days off where wife and I have gone up the beautiful British Columbia coast, not far from Vancouver, but it's a different world.
That's nice. Enjoying a mini vacation?
That's right. Mini vacation, because the big ones were all canceled due to COVID.
Yeah, unfortunately. Hopefully it's gonna get better soon, right? We can lose our hopes.
Fingers crossed.
Yeah. So thank you so much for accepting the invitation. I'm honored to have you here. Very excited for our conversation, and I'm sure all of my colleagues are too. And so let's jump right in. So could you tell us a little bit about yourself, your career, and how did you get to where you are right now?
Well, first of all, thank you very much for asking me. I'm very flattered that you'd want to interview me. So I am originally from the UK. I was born in London. When I was young, only 7, my family immigrated to New Zealand. So I had almost all my education there. And while I was still in high school, I found out about physiotherapy and decided that was the career path for me. So after I had graduated in New Zealand, Brian Mulligan and Robin McKenzie had just started a manual therapy group, because there was a void. There was no one teaching that in New Zealand. So they started that, and they were offering classes. And I started taking them in my first year that I'd postgraduate. And that's where I met Brian Mulligan and I met Robin. And by a lot of good fortune and luck, well, same thing, luck and good fortune, I ended up working for him for a year. Fortunately, we hit it off, and he very kindly took me under his wing. And I ended up working for him for a year. And that was interesting because it was really the start of the McKenzie Method. At that time, he was still doing a lot of manual therapy. He was following the Kelton-Bourne system. The New Zealand manual therapy group was largely based on Kelton-Bourne and Syriacs. And Robin was in that transition stage. So when I was with him, all lumbar patients, we were using his McKenzie, what we call MDT, the McKenzie Method, but the cervical, no, that was all hands-on manual therapy. So big changes. I've seen big changes in my time.
That's so crazy. You're so lucky to be there on the right place, on the right time, with these two brilliant minds.
Mariana, one brilliant mind. It was sheer dumb luck. Now I would not get into physiotherapy school. There's no way I would get in. It's become so competitive, and it all seems to be based on marks, and the result is you don't necessarily end up with the best candidate. Robin wouldn't have got in. So some of our great people, Brian Mulligan wouldn't have got in. So some of our great minds in physiotherapy would not have qualified under the current system, which is, there's something wrong there.
Yep. It has to be something wrong if they wouldn't get in. would not have these two brilliant techniques, right?
Yeah, it's true.
So let's talk a little bit about your experience with Robin. So what do you think that was the most valuable thing that you learned? So how was that experience?
What I learned, I didn't learn at the time. That may sound strange. I was young, very naive, and the undergraduate training that was offered was not very good. The basic sciences of anatomy, physiology were very well taught. But the treatment, how you went about managing patients, especially in the musculoskeletal field, was, I'm struggling to find the words, but incredibly inadequate. So those were the times of electrotherapy was very dominant. So if you were seeing someone with a back pain, it was the treatment was more or less prescribed. They got heat of one form or another, but you could choose between infrared, microwave, or shortwave diathermy. So there was some serious thinking to be done there in deciding which form of heat. But so that was a very poor background to come from, and I think looking back, I probably found it a little overwhelming. I wasn't prepared for what I saw from Robin. He was so far ahead in terms of the way he carried himself. Physiotherapists at that time were a pretty downtrodden lot. The doctors, especially the specialists, the gods were the orthopedic surgeons. They didn't think a lot of physiotherapy. And the physiotherapists tended to be quite, I'm just trying to think of the word that would best describe it. They had fairly low self-esteem, but not Robin. He was totally different. He looked like an eminent specialist in his field. That's why he carried himself. That's why he portrayed himself. And he was able to mix with these orthopedic surgeons on a level ground. He could easily hold his own with any of them because he realized that they didn't know anything. So there was that part. And then the other part was he had an understanding, such a clear understanding of mechanical pain. That concept was we hadn't been taught that. And what had been drummed into us was you've got to be very, very careful you don't make anyone worse. And so we were taught with a background of fear, which was really misplaced. I don't want to suggest that contraindications are not important. They're incredibly important. But the way that it was taught almost paralyzed the practitioners. You were scared to do anything. And so his approach was very different. And it took me a long time to come to terms with that. So I learned a tremendous amount, but I didn't realize I was learning it so much at the time. It was in retrospect when I was able to look at other systems and saw the difference that was the real value.
That's crazy. Imagine all this valuable information. Probably you didn't even the idea of how big that was going to be, right?
Well, that's very true. He always said that in his wildest dreams, he could not have conceived of how things developed. He was at that stage, and we're going back a long, long way. 1974. He was best known for the development of the technique for the lateral shift, not for the McKenzie approach as such. And I think it wasn't until he sat down and wrote the book, the first textbook, mechanical diagnosis and therapy of the lumbar spine, that he realized that maybe his concepts weren't quite as straightforward as he had thought. They were obvious to him because he developed them. They weren't obvious to a lot of people. They certainly weren't obvious to me. What I got by because I was a good parrot. I could repeat what I saw. I could repeat what he said, but I didn't understand it. That was the problem. And that understanding took quite a long time.
So it was in 1974.
Oh, yeah, I know.
It was a couple of decades ago.
Oh, well, it was certainly after the last ice age, but not much.
Oh, and I remember you mentioned that he had developed the neck technique. So he was on that time mainly treating lower backs?
Yes.
That was
mainly lower backs. He had asked his referring doctors to concentrate on referring in people with low back pain. And naturally, we would get them with the neck, but we tended to use more manual therapy. And it was probably, I was with him for a year, and then I left to go traveling. And I ended up in Canada, where I've been for the last 40 plus years. And after that, within the next year or two, he developed the cervical much more, and much later, the extremity.
Yeah, so that was going to be my next question. So after you stay with him for a year, you went to Canada, and then
not directly. I went traveling overseas. I had a backpack and I went overland through Asia, all the places you can't go now, Afghanistan and Iran, and
that's cool.
And then I ended up in Britain for a year. I worked in England for a year, and then I went to Canada originally to just for 3 weeks or so, or no, it was longer than that. It was about 3 months to see the Olympic Games and to work in one of the hospitals. And the inevitable happened. I met a young woman and fell in love and ended up staying there.
Okay, so then you start working with McKenzie techniques after that?
A bit after I dabbled in some of the other things, but Robin at that time, he was starting to teach the what we now would call the Part A, the lumbar spine. He was starting to teach that internationally, and he would make these long tours of at least 8 to 10 weeks, very, very arduous. And he'd go to Europe, Britain, Germany, and he would come to Canada, the United States, and he'd deliver a course in one city, move on to the next. It was a very demanding schedule. But he found that he wasn't able to keep up with the demand. So that led him to form the McKenzie Institute. And in forming it, he just turned to people that he knew. He turned basically to his friends. And that's how I got in. So I wasn't lucky once. I was lucky twice, incredibly lucky. Now people have to apply an enormous amount of effort to get the diploma, and B, to become teaching faculty. It's very demanding now. I almost feel guilty that this was kind of handed to me.
So I was looking up the information about your story. So it was in 84 that you start being a member of the teaching faculty?
About that, 84, I think, 84 or 85, something like that.
That's nice. That's a lot of decades too. So a lot of experience. So let's talk about the changes that you saw on the method over the years, because you were there on the very start. Yeah. And you've been teaching until today. So what do you think that changed since the beginning? Well, how was the evolution of the method?
The interesting part, the really interesting part for you and for your audience is how little it changed in a lot of ways. The basic principles that he describes in that first textbook, which came out in 1980, haven't changed. His description of derangement, his proposed treatment of derangement, the division into dysfunction, the assessment process, his assessment process changed very little. What has changed a lot is we now, it's not centered as much on the disc. Unfortunately, a lot of people have associated McKenzie purely with the disc, which of course it isn't. And I suppose the areas that have changed the most, I would think, from the way that he approached patients. Now, let me make a distinction there. A lot of people would say, okay, well, McKenzie now has seen more of a biopsychosocial method. Well, as far as Robin's treatment went, it was always a biopsychosocial method. He just didn't think of it in those terms, but it was what he did and what he did with his patients was very much biopsychosocial. He was although he had no training in psychology, he was extraordinarily astute at understanding those issues when they presented in the patient. And he would invariably put them in the right place. So they would never get in the way of the assessment, but he was very aware that they were part of the issue. And he would structure his instructions or his treatment to the patient accordingly. So that part really hasn't changed a lot. We talk about it more, but in his practice, Robin pursued that as well as anyone now practicing.
And do you think that was intuitive for him?
I suspect it was. I think it was. He was an extraordinary observer of all aspects, clinical, and aspects of human behavior. He was very, very astute in that way, and putting them into a context. I would say if he was to come back now and look at some of the things that are being done, a couple of them would probably surprise him. I think, and not just him, but have surprised all of us. And number one, I suppose, would be certainly since the ex-post study was published, and I'm sure your listeners will be familiar with that, or do you want me to just quickly describe it?
I mean, feel free to quickly describe if you want. Okay. It may help the audience.
Okay, so what it basically was taking a study that took a cohort of patients in multi-centers around the world presenting with extremity pain. So their complaint might be a shoulder, it might be a knee, it might be a hip. And the assessment process was to determine how many of those problems were actually coming from the spine and not from the extremity. And I won't go into a lot of detail on it, but suffice to say that shoulders is one example. Almost 50% of shoulders were found to be spinal in origin. That's a lot. It is a lot. And so the message is that we really hammer home now, you've got to clear the spine. And that's where Robin would have perhaps have been maybe mildly surprised to the extent you have to go to clear the spine. Just 5 years ago, we would have said end range patient movement would be sufficient. If the patient, for example, in the lumbar spine can get end range extension, when they do extension and lying, sag, feel no symptoms, we would generally have been satisfied that this was sufficient evidence that the spine was not contributing to the extremity problem. Now we're finding that to really clear the spine, you have to have overpressure right through the lumbar spine, not just L5, S1, but right up into the upper lumbar spine, sometimes into the upper thoracic. And also sometimes you have to do mobilization. A case in point was a patient that I had on a course. She was actually one of the participants, and she'd had 2 surgeries for labral tear in the hip. And the surgeries had not been successful at all. She was still symptomatic. This person was very flexible, very good range of movement. And when we were going through all the techniques, there was no discernible loss of movement. So she had full extension, didn't feel any tightness or anything. And so when I was looking at her, I started to go through the lumbar spine and apply mobilizations. Any area here where it feels different. And she identified in the upper lumbar. Oh yeah, that just feels different. It feels kind of stiffer. I don't feel it when I move, but when you apply that pressure to it, it doesn't feel the same as lower down. So after I had done this for a few minutes, she said, oh, that feels different. That feels more like the rest of the spine. We stood her up, got her to do her concordant tests, pain dramatically reduced. So that was one that a few years ago I would definitely have missed. The same thing in the cervical spine. The upper thoracic is enormously important. And you have to use a lot of overpressure to sufficiently be satisfied that you've cleared that. And then, even then, you have to keep coming back to it.
I think it's funny that you mentioned that, because I remember in Brazil in a course that I had with you, you were talking about that, and that I remember that very clear. You going putting a lot of pressure on the spine, just on the assessment to have an idea if it was coming from the spine or not. So
now I'm glad you said that, because that's a very important point. A lot of people beginning in MDT, we try to teach them, don't put your hands on too soon. You need to explore the patient's own resources, which is very true. But when you are dealing with an extremity, to clear the spine, you have to use your overpressure and hands-on very quickly before you can clear it. That course that you mentioned, I know there was one in Brazil where there was a young man with a shoulder problem that was very difficult to understand and to make any progress. And I thought I had cleared the spine by really pushing hard on that, mobilizing the upper thoracic. And he wasn't getting any better. I came back on the second day and pushed it even harder. My hands were hurting. And it took that amount in order to reveal that it was coming from, most of it was coming from the spine.
Yeah, so we don't have to be afraid to differentiate if it's coming or not.
No, you get, when it's differentiation, when you're doing the assessment, especially for an extremity, you have to use overpressure. You sometimes have to use mobilization before you can move on and say, no, the spine's not involved. So it is a big area of practice, which will change people's clinical results. I think the other one that would probably surprise Robin is the amount of derangements in the extremities. We're seeing a lot of those, and in populations that we wouldn't have expected. And one of the best examples of that is Richard Rosedale's study of the patients on the waiting list for knee replacement. And they found that 40% of them, their main pain driver was derangement.
Oh, wow.
In that population. So you can imagine in the population that isn't, and all of them, I should say, had very, very marked signs of OA. The imaging was very clear. They were in the worst category as far as imaging goes. They still,
Oh, wow.
one of the main pain drivers for 40% of them was derangement.
It's a lot.
It is
a big number.
It's a big number. It's a very big number in that group. And the thing is that no one else, as far as I know, is looking at extremities that way, that there's something in the joint which is obstructed or blocked, or the joint has a directional preference. And when you expose that directional preference, you can get dramatic changes. And that's still very new in the field of orthopedics. We haven't been able to get that message across as yet.
Well, we are starting now, spreading the word.
Yeah, it takes a long time.
Yeah.
It takes a long, long time for any of those things to change. Old habits die very hard. And one of the problems is when you go to look at what's being taught in the universities, you think at a university should be at the cutting edge of research. And often they're not. They are still teaching outmoded and discredited forms of practice. Certainly that happens here in Canada, which is very disappointing.
Yeah, yeah. It's sad. We have to keep up with the courses and try to be updated with everything. Any other topic that you want to talk about, the difference, the progression?
I think those two would for me they stand out. The whole advent of the extremity is so powerful, and Robin was really just at the beginning of that. He wrote the book in 1999. It came out. So 21 years ago. And the interesting thing is he didn't see a lot of extremity problems. He saw mainly spinal. So it was extraordinary that he was able to apply those methods so successfully to diagnose problems that now we're seeing a lot of, particularly derangement. And from the early studies, you can see that the number of faculty who were involved in the study to diagnose, or to classify, I should say, not to diagnose, to classify problems, derangement was quite low. When that study was repeated 6 years later, the derangement had leapt much, much higher. And I think if we did it again today, it would be higher still. And that has led to fortunately, it's coincided with other research, independent, totally non-McKenzie research, which is finding that a lot of what we thought was safe ground, we can diagnose this problem, we can diagnose that problem, because we've got the tests for it. But the tests have been found to be lack of reliability. All sorts of those tests, and that's well described in some of our literature. Some of the tests, for example, for rotator cuff, have been found to have poor reliability.
The special tests.
Yes, the orthopedic special tests.
Yeah. So I think that's another evolution, because we test functional, right? You test, it's very different from the special tests. And I think in the end, doesn't really matter what's going with the structure, right? It's the function, is how you move, how far are you able to move, how is your pain, and all of these things, than the structure itself.
Well, one of the best examples of that was a paper done by Asher Menon and Stephen May, Asher Menon of our India faculty. And it was a case report. Now, case reports, that's not strong evidence, but it was very interesting because it illustrates the point you were making. This was someone who saw an orthopedic surgeon because they were unable to work in a warehouse because they couldn't raise their arm over the head. And they did an MRI which found there was a complete tear of subscapularis. And there was, I think, a grade 2 slap lesion and indications of inflammatory tendinopathy. And fortunately, and the patient was scheduled for surgery. Fortunately, they saw Asha Menon first, and when she did a spinal evaluation, they found directional preference for this patient. They found the patient, after going to full range extension a number of times, they regained full painless range of shoulder movements. Now, when I think an MRI was done a year later, they still got a subscapularis tear. All of the findings of the original MRI were still there, but this patient had no symptoms, full function, back at work. So
how do you explain that, right?
Well,
to the patient,
well, I would say to the patient, what we're finding now is that many people who never have had a problem, they may get imaging on one shoulder, but of course the MRI gives you an image of both, and they find they had the same thing on the other one, and they've never had a problem with the other one. So this is becoming more and more reported in the literature. So you tell the patient what we thought we knew from the imaging. We're having to rethink a lot of our old ideas, because people can manage very well with all sorts of tears and damage they never knew they had. Doesn't affect their function at all. And when you think of what is necessary in a human or an animal, they've got to remain active. So there has to be backup systems to enable people still to function in the face of injury.
And I think still today, the image is the thing that we see that matters a lot for doctors, patients. So our model is still very focused on images, exams, to try to explain what's happening. So
that's true.
We are changing this a little bit.
Well, and the change has not come from us, meaning the physiotherapists. It's coming from medical research that you can't rely just on the image. It's got to complement what is found in the clinic, related to the clinical presentation.
Mm-hmm.
Yeah.
Yeah. So that's great. That's great. And now I want to talk a little bit about the strengthening, that I know it's a part of the treatment that you like. So how do you relate strengthening and McKenzie?
How I've evolved over the last number of years is I see, and this may answer some of your other questions, I see physiotherapy, or if you're a physiotherapist or a chiropractor or someone who practices legitimate forms of musculoskeletal therapy, and I'm talking about not all the bells and whistles and machines and things like this. People who use movement as a means of treatment. I see this now as not a secondary part of medicine, but a primary medical intervention. Because now so many of our problems of an aging population are physical problems that can lead to the comorbidities. You think of people with cardiac problems, vascular problems, pulmonary problems, even things like Alzheimer's, in some cases cancer. A lot of that is made worse, or the problem is contributed to by a lack of activity, a lack of proper activity. Now, some of those patients can't be sufficiently active, because they've got musculoskeletal problems. And traditional medicine has not been successful at treating these. you can't give medications for most of the musculoskeletal problems we have, if you exclude the inflammatory arthritis. Most of them for rehabilitation need some form of movement-based treatment. And it's such a powerful form of treatment. And so the way I've started to think of our profession, the musculoskeletal profession, is that it's one of tremendous importance, not just from musculoskeletal problems, but that in turn affects those other issues, so some of those comorbidities. Because if you can't move, you can't exercise adequately, you're more susceptible to some of those problems, which is tremendous burden on society. Now, so what I'm thinking now is that physiotherapy is an essential health service. It's a way of helping to keep people healthy. Now, that's where strength is so important, because from about the age of, say, mid-30s onwards, all humans are starting to lose muscle mass. And it becomes critical later on in life. And it makes people more susceptible to falls, to fractures, all of these problems of disability can stem from that loss of muscle mass. Now, you can't reverse it completely, but you can slow it down so much that even in late old age, it's not a critical problem in terms of the activities of daily living. People can still, if they can maintain enough muscle mass, they can perform those vital tasks of getting up out of a chair, getting up out of bed in the middle of the night, maintaining balance. A lot of that, the balance problems, not all of it, but some of it is due to a lack of strength. And it's so easy. It's the biggest disease that is unrecognized, sarcopenia. And it's so easy to manage. You only need to apply strengthening, real strengthening, probably once a week, and you can get have a very effective program for the health and longevity of patients. And this was really illustrated to me. I've been a runner for 45 years or more regularly. And I was finding about 15 to 20 years ago, I'm starting to put on more and more weight, and my pants are no longer fitting. They're getting too tight. And I happened to mention this to one of my colleagues, an exercise physiologist called Ted Dreisinger. And he said, "Are you doing any resistance training?" "No, I just run." He said, "Well, you're losing muscle mass. And when you lose muscle mass, you're taking away one of the large drivers of calories. The more muscle you have, the more your metabolism gobbles up those calories." And so what I found was, when I followed his advice and I started a strength program, I had to throw away a lot of jackets. They no longer fit because I got larger in the upper body, but the pants did fit. The ones that they started to fit again because I lost size around my waist. So I became convinced that, yeah, strength is terribly important. So now, in terms of McKenzie, you asked in terms of McKenzie, I include it in recovery of function. So if I'm treating someone with a derangement, naturally you'll follow the usual rules of directional preference. But then when it comes back to restoration of function, it's not just range of motion. I will tell all my patients, you would benefit from a strength program, just from general health. So I think that's one message I want to get across to all of you, all of the listeners, is you can do a tremendous amount of good if you persuade your patients. And the hardest ones sometimes have been women, because a lot of young women get the mistaken idea that if I do strength exercise, I'm going to get huge muscles and I'll look like a guy. Well, nothing could be further from the truth. You just have to look at some of the athletes at the Olympics, the female athletes doing extraordinary feats in terms of strength, and they don't look anything like Tarzan or men. But they're strong, and they should be.
Yeah. So in the recovery of function, you start the strengthening program, or you refer them to do strengthening?
And I generally give them, what I like to do is to give them a program myself. Personal training has become a huge industry in Canada, but it's done by people who are not really trained in it. They're certainly not trained in the management of people who've got musculoskeletal conditions.
Yeah.
And a lot of it is based on maybe fads, or it's a lot of it's lacking in science. And of course, because it's been commercialized, they want people to keep coming in all the time. It's funny. It's a little bit like the battle Robin had in saying you don't need to go to physiotherapy 3 times a week for 3, 4, 5, 6 weeks. Patients can be taught to treat themselves. I use the same principle in terms of strengthening. You give them the basic instruction, how to go about constructing an effective strength program. They can do it for themselves.
Yeah, I think that's important it's important to talk about that, because we that are trained in the McKenzie method, sometimes we forget a little bit about that part of the treatment. And I think people don't talk much about it. So I think it's good to hear that and to remember that strengthening is also important. We should be combining
it's terribly
referring,
important.
Educating the patient. So
yeah.
I think that's a good point.
Yeah.
And do you have any advice to the physical therapists that are starting their McKenzie journey?
Yeah. There's 2 things I think I would say. The first thing, I think the most important thing for someone starting out on that journey, don't treat patients. Now, I'm not suggesting you become an administrator. What I'm referring to is something that I struggled with for a long time. Every time I would get a patient, I would feel I had to treat them and get them better. And it wasn't until I took part in a research project where I had to assess people and make decisions on what might be wrong with them that I realized that all this time I've been trying to treat everyone. And it came to me right then that was Robin's secret. He didn't treat patients, he assessed them. His process was one of assessment. And so he felt he had no problem telling a patient, I can't help you. Most clinicians won't do that. They're terrified that patient will go somewhere else and get better and it will affect badly on them. The real strength of MDT, the McKenzie process, is if you use it as it's intended to, it's an assessment process. You hear sometimes people say, well, we tried McKenzie and it didn't work. It's like saying, well, we tried an x-ray and it didn't work. Well, what do you mean? The machine was broken? Well, no, the x-ray was taken, it didn't show anything. But surely that's of value. It tells you probably they don't have a fracture, or they don't have any serious potential degenerative condition of the joint. And so that's the advice. One of the main pieces of advice I would give is to make sure that when you approach a patient, it's with, I'm going to talk to you. I'm going to ask you questions. I'm going to do some tests. What I really want to find out is an understanding. I want to gain an understanding into the nature of your problem. If I can understand it, I'm much better able to tell you whether I'm able to help you. You can't treat effectively something you don't understand. And when you're successful, it's by chance, not by design. And so those tests are done on patients and you compile the results. Okay. Are we seeing directional preference? Are we seeing centralization? No. Okay. Maybe I need to do some more testing over a longer period of time. When we do that, we're not getting any clear indication of what the problem is, then it might be time for the patient to have some other form of investigation. But I can't emphasize that enough. That to me is the secret of the McKenzie approach, is emphasis on the assessing, understanding what is wrong with that patient. What is driving this problem? It might be psychosocial. It may not be mainly mechanical. So McKenzie method is so good at telling you who will not do well with this approach. That's one of its strengths.
And you can give a direction to the patient, so understanding what's going on. He's going to have an answer anyway, if you can help him or not.
Yeah, exactly. And that's very powerful. So I often say to my patients, look, I can tell you within 1 or 2 visits probably whether I can help you. I don't want to waste your time. If I'm not helping you, I'll tell you. And now, especially in these economic times, they really appreciate that. So that would be one of the biggest pieces of advice. The second would be, don't give up. A lot of people, they take the part A, maybe the part B, they dabble with it for a while, and then as soon as they strike some difficulties, they give up and, I'll go on. That patient didn't get better, so I'll go on, I'll do something else. I'll do IMS. I'll try the core stability stuff. They don't persist long enough. It takes a long time to become really competent in this approach. If you abandon it too soon, you're being unrealistic in your expectations. It's like expecting you go into medical school and after the first 6 months you say, well, I still don't know how to do brain surgery. I'm going to give this up. I'm going to go and become a lawyer. You've got to do the whole training. It's arduous. But anything really, really worthwhile does take a lot of effort.
Yeah, I can remember the difference after I've done the C and D, because when you do A and B, you have an idea and you start trying, but it's much more than that. So you can expect that that's going to be McKenzie. You got to. Yeah.
It takes a lot. It's deceptively simple. People say, oh, well, is that all it is? You're doing a few push-ups. It's, as you know, it's way more than that.
Yeah.
So that would be the other thing. Don't give up. If you become interested in it, work at it. It takes effort. It takes effort to succeed at it before you'll get reasonable results.
Yeah. And you got to test in many patients.
Testing. Yeah.
So now I want to transition to the final questions.
Yep.
Do you have any resource of information that you would like to share with us?
Well, now my biggest source of resource would be my colleagues. Talking to them and in terms of what they're seeing. That for me now is my biggest, because all of us are still learning. But in terms of resources, the McKenzie Institute website, if they go on the McKenzie Institute website, there is a list of abstracts, and they're divided up into different categories. That would be a very, very good resource.
You're talking about the articles that they have there?
Yes, they're abstracts. You can't reproduce. We can't print the whole articles for copyright purposes. But 2 in particular, I think everyone should read. One is Kevin Spratt's ADTO model. Just very briefly, it's Kevin Spratt is. I'm not sure what his title would be, but his main function is to design research projects. So he's got a tremendous knowledge of things like statistics, study design, how to design a good study that is going to stand up to scrutiny. So that when you design a study, you can be fairly confident that the results that you've got are going to have significance. And so, very briefly, what he reports is, and anyone going into physiotherapy needs to read this. First of all, you cannot treat something if you do not have a validated way of assessing that person. You would need to have reliable and relevant tests that have stood up to robust scrutiny to be able to make a diagnosis. What are you basing that diagnosis on? Those tests have got to be good. If you are able to now to make a diagnosis, what is the best treatment for that particular problem? An example would be, once it was discovered that angina was due to an ischemia of the cardiac muscles, then that opened up possibilities in terms of treatment. You could say, okay, an effective treatment might be a way of increasing the blood flow. So then vasodilator drugs and things like that. And then once you've done that, you've come up with a treatment. That's when you apply your randomized controlled trial, not earlier. So many randomized controlled trials have been a total waste of resources because they're done on back pain. Back pain's not a diagnosis. It's a symptom. I've got pain you go to the doctor and you say, oh, my back hurts. The doctor looks at you, does some tests, and says, I know what's wrong with you. You've got back pain.
No kidding.
Yeah. So it's a tremendous resource article. Everyone should read that.
I'm gonna make sure to put on the show notes.
Yeah.
And you said one more? You said that you had two, or that's it?
Oh, I know another one that really made a difference to me. It's a fairly obscure paper, but it really resonated with me. The author's name is Gillard, Gillard. I wrote down the. It comes from a journal called Connective Tissue Research, and it was way back in 1979. That's more recent for me, but for a lot of the listeners, that's before you were born. But that paper was on the glucosaminoglycan content of the flexor profundus tendon of rabbits. Now that seems like a fairly funny sort of research paper to be significant, but what they did in this study, an earlier study had established that the glucosaminoglycan content of this particular tendon was different in parts that were wound around a bone. So much like our everter tendons, where they contact the ankle bones. And so they found that the glucosaminoglycan content was very high in areas that were pressing against a bone to protect the tendon. So there was a lot more fluid. There was a cushioning effect. In the other parts where the tendon was taking tensile forces, the glucosaminoglycan content was very low because the tendon now is mainly consisting just of collagen for its tensile properties. So what Gillard's team did, they did a tendon, altered the course of the tendon so that the part that was taking compressive forces was now taking tensile forces. And the astonishing thing was they found that there was a 60% drop in the glucosaminoglycan content in only 8 days. So what said to me was, wow, that really drove home to me what a powerful, powerful tool we had in the form of specific load and movement. And I'm thinking, why are they still teaching all this rubbish about electrical gadgetry that has done, none of the research has shown any benefit. Well, we've got this really, really powerful tool that really affects the structures, our human structures. And at the time, it was thought that tendons were, they didn't do very much. They were pretty inert. This shows that living dynamic structures can be changed enormously by load. So it influenced me quite a lot in that respect. It really reinforced the importance and value of loading tissue and understanding the differences in load. And that's for me what physiotherapy, I shouldn't say physiotherapists, I should say clinicians, because many chiropractors and other practitioners are using the same approach, using the MDT approach. It's not confined to physical therapists. But those clinicians who are involved in that field, movement is, they need to be understanding the intricacies and the details of movement and applying it. What's the best load strategy for your particular patient?
Yeah, I think that's huge. And it's again, what we talked before is movement, is the strengthening, is load. And I think it's more and more less passive treatment and more active. That's what I've been seeing.
Well, and that's true, but then it has to be specific. Movement has to be specific to what you're trying to achieve, and then that comes back again to assessment.
Yeah, yeah.
Because if you miss a derangement and you're treating it as a tendinopathy, that load, which is very important if it is a tendinopathy, will not help the patient because that's not their problem. The problem might have been one of derangement. So it all comes back again, circles back to
good assessment.
The assessment, yes.
Yeah. So I think that's all great resources and articles, very relevant. And so we talked about advice to physical therapists that were starting the McKenzie. Do you have any other advice to physical therapists starting their career in general?
What I said, I suppose, to the MDT people would apply. I think when you're starting your career, be proud that you're going into musculoskeletal medicine. Be proud that if you're going to become a physical therapist, if you're going to become a chiropractor, be proud of that, but develop those resources that maximize patient empowerment. And the other piece of advice I would give is don't jump on bandwagons. The history of musculoskeletal medicine, and particularly in physiotherapy, has been a bewildering array of fads and fashions. And when I look back on my time in the field, we had, in terms of back pain, we had Williams flexion exercises. Everybody was doing those. And then, we don't do that anymore. There was, we'll do McKenzie. It's all extension now. And then, it's core stability. All these trends, and we throw the baby out with the bathwater. And a lot of these trends are just that. They're fashions. They don't last because maybe they didn't have good science. They didn't have the essentials of that ADTO model, the importance of the assessment. They didn't have that behind them. So be skeptical. Don't jump on bandwagons because it's supported by the majority, because those things change. If you look how things have changed in medicine 30, 40, 50 years ago, some of those concepts that we had, they're not current at all.
It's a lot of techniques. We see it's a lot of techniques to treat patients coming up all the time, but it's not like the good reasoning, rationale behind the assessment.
Oh no, that's very true. Very true. A lot of people, when they go, I want to learn some tricks. Well, if you want to learn tricks, go to the circus. Join Cirque du Soleil. good clinical reasoning, I think, take us the furthest.
Yeah. And last question. So what personal abilities or qualities do you think are important to become a successful therapist?
Become a successful clinician, I think, and again, I think Robin would be a good model here. He genuinely cared about his patients, genuinely cared. And in the field of medicine, I think we all understand that there are people in medicine who don't care that much about the patient. The patient's interests are not necessarily their first priority. It's, well, I can make a really good living out of this. So the first thing is you must have compassion, empathy, concern for your patients, and you should be doing everything you can to empower that patient to help to solve the problem themselves. Now, Robin was wonderful at that. But if the patient didn't want to learn, then he had no problem saying, "Oh, I can't help you.
Yeah,
I'm not able to help you." So having that compassion, and which also goes to another aspect, you've got to have an interest to be a sort of I suppose in medicine you've taken on the role of a healer to some degree, and so you have to have an interest in that field. You've got to keep do your best to keep current, keep an open mind, and to keep on developing yourself as a clinician, striving to improve. I understand it all. None of us do. None of us understand it. We understand parts to some degree, but we need to keep that that idea of a certain amount of humility. I've got to keep learning, because we even now at this stage, it's more than 50 years I've been in the field. I'm still seeing patients that I haven't seen that before. I haven't seen that particular presentation. It's new, it's novel. Keeping that, and I suppose that interest or excitement is important. In that excitement, it goes back to what I said before, having an interest in the patient. If you've got an interest in the patient, you're excited by what you see. You enjoy that contact. It's almost like you're the detective in a mystery, and you're trying to find out what more about this problem. You're trying to get an understanding of it.
And I think that's fascinating that it keeps you interested in trying to solve problems, because it's not all figured out. So it's still challenge seeing patients. So it's not like, oh, I've been doing this for, 50 years. I know everything. So I think that's what's so excited about our profession, that you're always going to have challenges. Not like everything's the same. Every patient is different. So I think that's what keeps things interesting.
Don't use formulas. So often patients will come and they'll describe their experiences they've seen with clinicians. They'll walk in, they'll start describing, oh, it's this, and this is the treatment that you need. And it's treatment by rote, treatment by some sort of theory or dogma, without really trying to understand it. I think a lot of it comes from a fear of being wrong. You've got to be prepared to consider, I don't know what this is. I haven't got a clue. Often clinicians who are insecure, they'll make something up. And this is not, I'm not talking about physiotherapists necessarily. I'm talking about in medicine. People in medicine don't like often to say, I don't know. I don't know what this is. But if you say that, I don't know what this is, then the next thing that will come into your mind, well, how are we going to find out what it is? And so that will involve thinking or using resources outside what you've normally used.
Yeah, it takes a lot of courage to do that. And And that's the way of improvement. If the first step is admit you don't know, right? So then you can move forward going after the answer. So I think we wrapped up everything. We talked a lot about a lot of different topics. Anything else that you want to add before we finish?
No, I think I'd be sending your people to sleep if I probably have already. They probably heard enough from me.
Yeah, it was amazing. If people want to know more information about you, is there any way of your contact information or anything?
I don't imagine anyone would want to know more, but I think they can probably get any contact information through the McKenzie Institute.
Okay, I'll put the website there.
Yeah.
And Colin, thank you so much. I'm very happy to have you here to learn about all the journey you have so far, all your experience. I think it's amazing. It's a big, big gift for all of us that you wanted to share all of this knowledge and experience that you have. And I'm really impressed with your story and all the trajectory that you had so far. So thank you so much for participating today. And I hope our listeners are going to benefit a lot from everything we talked about today.
Well, I thank you for asking me and B, for doing this. What you're providing is a very valuable resource, but especially at a time like this. This is one of the great advantages of the technology. It's being used to its best. So thank you on behalf of all the people in the McKenzie Institute for doing this and helping to improve things for people who really matter, which is their patients.
Great. Thank you.
Okay.